Okay, welcome everybody. Thanks for joining us this afternoon or morning, depending on which time zone you're sitting in. My name is Paul Hartshey. I'm the CEO of RevCycle Partners, and just want to thank all of you for joining and spending some time with us to dig through the topic of credentialing new providers. First, I'd like to thank PECA. We've got a long-standing partnership with PECA. I appreciate the opportunity to always present to the PECA member base and interact with PECA. We'll be at the PECA annual meeting next month in Nashville, so hope to meet some of you in person there. A little bit of logistics before we get going. We are recording this webinar, so if you have to jump off in the middle of it for some reason, we'll send you everyone a link to the recording. And if you find the information useful and you want to forward it on to others in your practice, that's obviously fine as well. And we will be doing, everyone will be muted as we go through the webinar, obviously just to kind of keep down on the noise. And we'll do a Q&A session at the end. So feel free to enter your questions along the way, and we'll do a Q&A session as we go. With that, I'd like to introduce Dave Kegel, who's going to take us through the topic today. Dave is the credentialing manager at RevCycle Partners. He manages the team and all the projects that we do. I think last year we did a couple hundred credentialing projects for a variety of customers. And so Dave is knee deep in this topic. And so with that, Dave, why don't you introduce yourself and get us going?
All right. Hello, everyone. You guys are all having a good day. As Paul mentioned, we're going to be talking about credentialing today, and we're going to focus on credentialing a new provider. With that, Paul mentioned, my name is Dave Kegel. I manage the credentialing team here at RevCycle Partners. First one, part of the credentialing a new provider that I wanted to talk about was just the application itself. Some of the inherent, complexities of credentialing applications are, determining, how an application is submitted to a particular insurance payer, whether that's some, believe it or not, still use paper applications, that maybe you want to email it in or fax it in. A lot of the payers these days are going to online portals. So there may be a portal that you need to use, or there are some, Cigna is one, I believe, that you still can call them and you can submit an application over the phone with them, which is actually kind of nice. The next thing to be sure of is that you have the correct application depending on what you're doing, right? There's different forms for different things. Whether you're, credentialing a new applicant, this is it's a new provider to your practice, but if he's already on the panel in your state, if he's already on the payer panel, then it would just be a demographic change, which would be a different form than a new application. Down the road, you got to make sure you're not using, credentialing a group, using the form to credential a group versus an individual. And some other things, you might be changing the name of your provider. So just make sure that you use the correct form before you start. You don't want to, fill this out, get it submitted, and then wait only to find out that you submitted the wrong form. You want to determine ahead of time if you want to credential the provider with, if you want to make sure and include Medicare Advantage plans that payer offers, or if you're doing Medicaid, if you managed care organizations in your state. So many payers are going to ask you many of the commercial payers will ask you for a Medicare or a Medicaid ID. So you want to make sure that you have those handy. And if you don't, then you would want to start with Medicare, right? That would be typically what we do is, for a new provider, we start with Medicare. so we can get that Medicare ID, and then and then Medicaid follows that, because Medicaid usually asks for a Medicare ID as well. Next topic is I want to touch on is closed networks, which is unfortunately happening. Continues to happen depending on where you're located. A closed network, it doesn't. It's not always completely closed, but usually what it means, they close them because there are, the insurance payer feels that there's no room, or that they have, for any more providers in that specialty in that geographic area. And that can be the entire state, or it could be, the county, or even just a zip code. Right. So that decision sometimes can be appealed. Sometimes, depending on the payer, you'll get the denial letter saying that the network is closed, but some payers will actually offer you, to send a second form to fill out if you want to try to appeal that decision. Some payers, they don't take any appeals. But it's always worth a shot. You want to try to appeal something that makes you stand out in the area. For example, speaking a special language. We were successful at one point getting somebody into a closed network because the provider was Korean and spoke Korean, and most of the patients in that area spoke Korean. So we were able to get that provider in. As far as how frequently you should check, a closed network can open up at any time. So it's, if you can check quarterly, I would say, especially the beginning of the year. A lot of times they'll open the beginning of the year. And if you have time, you can check monthly, because it's usually first come, first serve. And something to be aware of that sometimes you can prevent this or the running into these closed networks if you have group contracts. Because if you already have a group contract in good standing, that you have your providers are already in network, adding a new provider to an existing group, sometimes you can skirt the the closed network thing, as opposed to adding a new individual provider. The next topic is Medicare and Medicaid. We touched on it briefly, but I just kind of wanted to go over this, to let you understand that, the government applications are usually more difficult. They're pickier, and they require more documents and information. Best to credential with Medicare first. And then as far as Medicare, you credential with the doctor with Medicare first, and then you reassign their benefits to the group. For Medicaid, every state is different, so it's important to understand the process in your state. For example, New York requires a paper application that you have to send in, USPS. Other states, like we mentioned earlier, may require you to use their portal. Some states have a Medicaid enrollment fee for new facilities and practices, not necessarily for a new provider, but just be aware of that. But in many cases, the fee can be waived if you have an existing Medicare ID. And then another suggestion that we have is to, if your state offers a state plan, newsletter related to Medicaid, sign up for that in order to be aware of changes in your area to the Medicaid program. That can be helpful. Next thing I wanted to touch on was specific issues related to credentialing and OD. When you're credentialing an OD with a medical payer, it's important to be clear that you want to enroll your provider with medical. Otherwise, they will steer you towards their vision provider. For example, Humana is going to send you to Spectera. Other ones, Cigna might send you to, IMED, so the different medical payers who have, who work with these vision providers, or vision payers, they're going to send you to them first. So as soon as they hear that it's an OD, so you have to be clear and say, no, we want to enroll the doctor with the medical plans. The other thing to be aware of is that third-party administrators are very common, especially for the vision payers. For example, if you are credentialing with Superior Vision or Davis Vision, you're going to do that through Versant, right? And Versant, you're probably familiar with Versant. That that's usually who you get your reimbursements from, who you file your claims with. But as far as credentialing, the Versant is not an insurance payer; they're a TPA. And there's other ones like that. Some medical insurance companies partner with and require credentialing with vision payers. We touched on Humana and Spectera earlier, but a big example is Aetna and IMED. Aetna has a nationwide agreement with IMED, and in some states, you even they make you credential with IMED. Make you be an IMED provider in order to get added to enrolled with Aetna. In other states, they are still the TPA, but you don't have to be an IMED provider if you don't want to be. California, as an example, requires you to credential with IMED. Anthem Blue Cross in California requires you to credential with IMED before you can get on the Anthem panel. So it's kind of a pain, but it's something to be aware of. And these alignments can change too, right? Sometimes it can be hard to keep up. Cigna, as I mentioned earlier, they used to partner with VSP, but now they're using IMED, at least in some cases. So something to be aware of is the partnerships between the payers. Next topic is new grads, and it's that's actually that's the time of year for the new grads graduating school, and a lot of practices are hiring new grads this time of year. In order to credential a new grad, they're going to have to have an MPI, of course. Going to have to have their CAQH set up. Going to need their license, and you also have to have liability insurance. You don't have to wait until they graduate or until they have their license to start set up your MPI, get your MPI and your CAQH. You can get a head start on that so that you're not doing all this after they graduate. There's a student taxonomy that you can use when they're still a student, and you don't have to put in their license. You can come back afterwards and put in their license number. The other thing to be aware of, and this is kind of tough for everyone, is credentialing is still taking quite a while. It takes 90 to 120 days. So it's best to have a plan in place for for your new grad as far as seeing patients before they are credentialed. Usually this would be, they could see cash patients or patients that can be billed out of network. But one thing to be aware of is you cannot have the new grad see patients and then bill under a different provider. They let you do that in optometry school, but you can't do that in a practice setting. The next slide, we talk about the follow-up process. So once you have got your application submitted, you want to follow up 2 to 3 weeks after the initial submission. What you don't want to do, you don't want to wait much longer than that, because it's not uncommon to reach out to these payers, even if you get a confirmation that it's been received. You don't want to wait too long and reach out and find out that they haven't started on it, or they never really got it, or whatever. So follow up, 2-3 weeks after submitting, to make sure that they have the application and it's being worked on. And then follow up every 30 days or so after that, just to make sure that it's still being worked on. There's different departments and things that the application goes through process wise. Goes through credentialing, and it goes through contracting, right? So halfway or so, at some point in the process, you're going to get a contract to review and sign. So following up kind of lets you know where it's at in the process. It can be frustrating. It's very hard to get a hold of people, at the insurance payers, and very hard to get a response. A lot of times there's nobody to call. You have to, send email, or you just check status on the portal. So you have to be patient, but you also have to be persistent. Finally, I thought I would go over a few tips I'd share with you that we've kind of learned during the credentialing process. Either we learned it ourselves, or we've learned it from talking to practices that have attempted to do this on their own. First one is we feel that it's best to assign the credentialing responsibility to one person. It's better to have a single point of contact for your payers to send notices to. The more people that you have working on credentialing means the greater the chance for error, right? So if you only have one person doing it, there's no chance that there's going to be a mix up in responsibility. You won't have the one person thinking the other person is taking care of it, things like that. So it's best to just have one person with that responsibility. Other thing we recommend is use a practice email address. Do not use a personal email address. And I can't tell you how many times we see that, where somebody has used a personal email address and they've either changed their email address and they no longer monitor this, or this person has left the practice. So, the payers are sending, requests for information during the application process that nobody is receiving, or later on, you get a revalidation notice, recredentialing is due, and nobody gets the notice, right? And then so you end up getting they term the provider with that payer. So it's important that you're using an email address that's being monitored. It's important, of course, obviously, to be organized with your data. Keep your emails related to credentialing. Keep your documents, store them electronically. And then, depending on the size of your practice, how many payers and providers that you're working with, you might even want to think about keeping a spreadsheet so you can keep track of, which provider is has, which application has been submitted to which payer and when. Keep your dates and where you're at in the process, so you can kind of keep track of where you're at, and when you need to follow up and things like that. So keeping a spreadsheet or something like that is very helpful, because it can become overwhelming if you're dealing with several payers or several providers. And then when chasing down an issue, or trying to follow up, it's important that you speak to somebody in the credentialing department, not just, plain old customer service. Customer service is not going to be able to help you. They're not going to have the latest information. So make sure you get a credentialing rep. And if you happen to get a good one, invaluable. So hold on to their information, whether it's an email, phone number, or whatever, because if you find somebody that's helpful and responsive, that goes a really long way. Yeah. Let's see. So that's it for credentialing a new provider. Paul, did you want to talk a little bit about
Yeah,
our
sure.
services?
Thanks. Thanks for all the information on the provider credentialing, Dave. As our just kind of a reminder, everyone, I'll spend a little bit of time going over our services, but feel free to enter any questions you have in the Q&A box, and we'll go over those in a few minutes. So feel free to send your detailed Stump Dave questions into the question box. So at RevCycle, we have two flavors of our credentialing services that Dave and his team take care of for practices. Probably the most obvious one or a common one that people think about are projects based on events happening at the practice. You know, you hire a new associate doc, or you're adding a location. There's a lot of practice acquisition and mergers going on. An employer in town switches medical plans, and there's a new payer you want to get a credential with. You know, all those variety of events that cause credentialing to be required. Dave's team can take care of that, and they're all custom projects. As you can imagine, each practice is unique, different number of doctors, providers at the practice, different number of payers. We see a wide range of quantity of payers that that a practice works with, and those variables, you know, have a huge impact on the effort required for us to do the work for you, and therefore the cost. So basically, the process we go through for a custom project is we'll work with you to understand exactly what you're trying to accomplish. What are the payers involved, or the doctors, or a new doctor involved, and we will create a custom quote for you based on the specific activity that you need done at that time. So that's custom projects. The other credentialing service we have is our maintenance services, and this is a way for you to offload that kind of ongoing background noise related to credentialing. It's as simple things such as just managing your CAQH and getting that updated and attested to as needed. Revalidations. When we take on a new maintenance customer, we'll build a calendar of every doctor's re-credentialing date for all the payers that a practice is working with, and we'll proactively take care of all that re-credentialing that needs to be done. And so again, just kind of taking that, trying to avoid some of those issues that Dave alluded to with respect to notices not being followed up on or not being received. We just kind of take care of all of that and organize all that for you. We do, Dave alluded to or suggested, organizing your data. Part of this process and this maintenance service that we provide is we organize that data for you. So we have a secure repository where we store all that information that you need, or the practice needs, or we need to do the credentialing for you. You have access to that repository. You could sign documents and see status there and things like that. So that service is an ongoing monthly arrangement, and we just charge it based on number of docs in the practice, and take care of all of that for you. So those are our services. The promotions or the arrangements we have with PECA, all PECA members get a 5% discount off of all credentialing projects, regardless of size or shape. And then we all, as Dave alluded to it, this is a new grad planning kind of time of year, and so we have a program where you can reserve a spot for your new grad ahead of time. If you're hiring, you may already have somebody selected and waiting for them to graduate in May or June. And if you want us to take care of that credentialing, we'd encourage you to reserve a spot. We just ask for a $250 deposit, and that will lock in a spot. It just helps us manage our resources and get you a slot for when your graduate gets his or her license. So with that, we'll I guess one thing I'll do before, feel free to enter any more questions. I see a couple coming in. I was going to launch a poll here. Let's see. Yeah, just kind of curious how many folks are actually looking to hire a new grad this year, and just kind of more curiosity. Contact information up here. Reach out to us at any time. And again, as I mentioned, we'll be at the PECA meeting in April in Nashville, and happy to chat with you folks. Anybody there. Let's leave the poll open for a little bit. It looks like about 50-50. That's our expected new grad hires this year. So thanks for that. Okay, Dave, ready for some questions? Let's dig into those. First question has to do with a cold start. I'm opening a cold start with just myself. Do I need a group NPI?
It depends on you know the how your organization is classified. Usually, if you are if it's the individual or sole proprietor, most payers will not allow you to have a group contract, and so you do not need a group EI, right? As opposed to an S corp or an LLC or something like that. So. So no, you don't always need one.
Okay. Next question is related to the kind of a follow-up to a topic you hit, Dave, on the new grad or the doctor, seeing patients prior to getting credentialed. It says, can I bill under the owner while waiting for the new grad to be credentialed if the owner reviews the charts?
No, you cannot. I will admit I am not the billing expert. That's the other side of the business, but I have been told that has people try that. But no, you're not supposed to do that. You can do it in as I mentioned, you can do it in an optometry school setting. That is allowed. The payers allow that, but once you're in a practice, you can't. You're not supposed to be billing under a different provider.
All right, thanks, Dave. Next question. We are hiring a doctor from a different practice coming into our practice. Can you review the basic steps to get her credentialed?
Yeah. This is a very common one that we run into. The first thing to be aware of is they need to make sure and add their new practice and location to CAQH. CAQH in general, just, we touched on a little bit as part of the maintenance thing, but just in general, it's important to keep CAQH up to date with, make sure your license doesn't expire and things like that. But yeah, they have to add the new location if they're moving. And then if it's within the same state, so if that doctor is already enrolled with the payer in the same state, then it's just a demographic update. You basically just reach out to the payer and give them the new location and address, tax ID, that kind of thing, where they're going to be practicing at, or add them to the group contract. If it's a medical payer, and if it's a larger practice and they have a group contract, then you add the new provider to that. If it's a new state, if they're moving from one state to another, which is also pretty common, then it's a new application that you have. And then, once the doctor is settled, it's you can remove their old location from CAQH, and then on the flip side, if you have a doctor that's leaving, also you probably want to make sure and term, reach out to each payer and term that doctor. Otherwise, they're going to continue to show up in the provider directory, and you're going to, you'll get patients asking about that doctor who's no longer there. So
good. Thanks, Dave. So the last question we have, one more question in the queue. Feel free to add more if you have one. But the last one we have today is, how much does it cost to credential a new doctor at RevCycle? I'll take that one. So the big answer there is it depends, right? And Dave talked about a bunch of the variables. Probably the biggest variable is the number of payers. You know, we're basically charging or quoting, you know, on a per application basis, and so depending on the payers and the payer mixes, we charge a little differently for Medicare, Medicaid versus commercial payers. But the best thing to do is just, you know, give us a call or reach out to us. We'll work through, you know, that list with you and what you want to do. The fees also differ based on the situation that actually Dave just talked about it previously, you know, whether we have to do full applications because it's a brand new grad or somebody moving in from a different geography. If we're only doing demographic updates and that affects the price, it makes, you know, easier for us to do and then cheaper for you to have us do it. So it really depends on the situation. The best thing to do is just give us a buzz and we'll walk through that with you and provide you a quote on it. So let's see, one more. Here's one more question that sneaked in on us, Dave. Can you speak a bit about locum tenens billing in relation to credentialing a new provider?
Very little. As I mentioned, I am not a billing expert, but I believe I do believe there's a time limit on that. I think 60 days. The payers will, and most of the payers I think follow Medicare's rules on that. So I think you can bill locum tenens for 60 days. Like if, for example, if you have a provider that's, you know, out on maternity leave, as an example, and you have somebody filling in, then you can bill under locum tenens in that scenario. It does not cover, you know, new grad, you know, new non-credentialed providers that are part of your practice. Now, you know, how does the payer? I don't know how the payer knows that, but I know technically, you know, it does not cover like new grads. They have to be filling in.
Got it. All right. Thanks, Dave. I think that's it. Dave, thanks for the time and the coverage of the topic. Thanks everybody for joining us today. And again, thanks to PECA for giving us the opportunity to work with them and their members, and hope to see everybody here in Nashville. Thanks again, everybody.
Thank you.
Thanks, Dave.